This is an interesting chapter because it has two almost completely independent topics in the chapter. Both of these topics cover roughly half a chapter's worth of material, and they tend to be combined in most abnormal psychology books simply because, well, that's the norm. There's really no good reason to combine them other than that they're both short topics. Because this chapter is essentially two unrelated topics, we're going to cover it as if we had two short chapters. In this section, we're going to talk about what used to be called somatoform disorder, now it's called somatic symptom disorders. And in the next section, we're going to be talking about dissociative disorders. This chapter, or this section of the chapter at least, focus on somatic symptom and other related disorders, all of which are characterized by bodily sensations experienced as physical symptoms, and which affect the way the person feels, thinks, and behaves. What draws them together is that there's no evidence for a physical cause for these physical sensations. Now, in the most recent DSM-5, there have been major changes to some of these disorders, and in most cases, the disorders have been renamed. I'll point that out as we're going through. They are called somatic disorders or somatic symptom disorders, or the old name, somatoform disorders, because soma means body, so these are body disorders. But they were called somatoform because they took the form of physical disorders, but without a physical cause. Often the individual is preoccupied with health and very focused on that. We are going to cover several of these disorders, most very briefly in this section. These are the disorders covered in the lecture today. The deliberate falsification of symptoms is called malingering. And when people malinger, there's usually a conscious awareness that they're doing it and a reason for them doing it. It might be that they have a lawsuit pending or that they have a disability claim pending. And so faking the symptoms has a financial gain for them. We know from Rosenhan's study that it's relatively easy to be admitted to a psychiatric hospital. At least it was in 1973 when that study was published. And we know that doctors tend to believe what their patients say. So if the patient is trying to fake an illness, the doctor may accept what the individual is saying unless there's reason to believe that the individual is trying to do that. Often second opinions are obtained in situations such as disability claims by independent doctors whose job it is to suspect that there might be a basis for malingering. The next disorder is particularly intriguing. It's now called factitious disorder. Previous term was Munchausen syndrome. In this case, the individual is presenting physical symptoms, often unconsciously, but occasionally consciously, not to gain a financial advantage, but because they need social support. We all need social support, and if you're not able to get it from other sources, having people feel sorry for you because you have some serious physical problem is a substitute. A variation, Munchausen syndrome by proxy, which is now called factitious disorder imposed on another. That's a more accurate description, the new label, but doesn't have the same panache as factitious as Munchausen syndrome by proxy. This is a situation where a parent, usually the mother, deliberately makes her child sick, sometimes dangerously sick, so that she can get social support because of the sick child. Now, in most cases, these are individuals who are terribly bad at getting social support. Getting social support requires establishing relationships with other people that are symbiotic. You provide them support, and they in turn provide you support. Over any given short period of time, you may provide more support or less support than they do. But over a longer period of time, you both tend to reach out and help each other. If you cannot establish those kinds of relationships, getting the social support from having a sick child may be a substitute. In many cases of Munchausen syndrome by proxy, the woman had a child who was indeed physically ill, and she got a lot of support from family and friends and neighbors because her child was ill. And then when the child got better, she stopped getting the support, and that was probably the reason that she reached out for support by making her child sick. Now, you can imagine when someone discovers that you made your child sick, they're not going to give you any social support. So it truly backfires once it's discovered. The next disorder is now called somatic symptom disorder. I will probably call it somatization disorder simply because I'm so familiar with that term. It's also known as Burkitt's syndrome. Like many disorders, the person who first identified it often has the disorder named after them. These are individuals who present lots of physical symptoms. They tend to be unrelated. They tend to change over time. So they go to the doctor a lot and they say, I'm feeling really lightheaded, or my arms feel like they're just falling off. They're so heavy. I'm having difficulty breathing, one symptom after another. It's a never-ending set of symptoms, and it is very rare that those symptoms are ever linked to any kind of physical disorder. Now, what's particularly interesting about this disorder is that it's 3 times more common in women than men. Well, there are lots of disorders that are more common in women than men, and there are lots of disorders that are more common in men than women. But it seems to be genetically related to what appears to be a very different disorder, antisocial personality disorder. Sometimes we use terms like psychopath or sociopath to refer to those individuals. That disorder is 3 times more common in men than in women. So we've got 2 very different disorders that seem to share a genetic base and tend to form one symptom pattern in men and a different symptom pattern in women. Now, we'll talk about this a little more when we get to the personality disorders later on. The next disorder was identified by Freud, and he called it conversion disorder. We have a new name for it. It's called functional neurological symptom disorder. And although that is a better name in the sense that it's more descriptive, most people still call it conversion disorder. A little bit about the history of this. Freud was a physician. More importantly, he was Jewish and a physician in Europe at a time when anti-Semitic feelings were fairly strong. So it was hard for him to get a lot of referrals. And he often got referrals from other doctors for cases they did not want to see. And specifically, it would be people who were presenting symptoms that couldn't possibly be the result of a physical disorder. Many doctors thought they were malingering or faking it or some other process. Freud, however, took them seriously. He knew that the symptoms they presented couldn't be the result of a physical disorder. He was bright and he was well trained as a physician. But he also looked at what they were experiencing and realized that it was still a disorder, even if it wasn't physical. And he noticed some interesting characteristics about them. And those characteristics led eventually to his theory of psychodynamic interactions, the unconscious defense mechanisms, all the things that make up Freud's theory. What kind of symptoms are we talking about? The individual might come in with a paralyzed hand, or they might come in with blindness, or selective blindness, or weakness. But again, there was good evidence. The next slide will show you the kind of evidence that we're talking about, that these weren't real physical disorders. He also was aware that the individuals who showed this symptom tended to show certain personality patterns. And those patterns had been around for a long time, and they almost without exception had experienced an enormous psychological trauma recently. So he speculated that the psychological trauma led to symptoms that somehow the individual converted from psychological into physical, hence the term conversion disorder. He also was struck by an unusual symptom that you don't normally see in patients. Imagine this: you wake up tomorrow and your hand is paralyzed. And so you look at your hand and you say, my hand is paralyzed. What's going on? Now, if I wake up tomorrow and my hand is paralyzed, I'm going to be really upset. And I'm going to want to seek treatment immediately. I might go to the ER thinking, oh my God, I'm having a stroke or something. Yet many, not all, but the majority of his patients showed a curious indifference, which he called liberal indifference. It's the French pronunciation. They'd look at their hand and they say, that's interesting. My hand is paralyzed. I wonder what that means. I wonder if I should do something about that. Maybe I should tell someone. Now, that's not the way people respond when something serious happens to them. And Freud thought that it was an awareness, but not in their conscious awareness, but in their unconscious, that their hand wasn't really paralyzed, that there was something else going on. So they weren't particularly concerned. You can see that this was the early underpinnings of the idea of an unconscious as well as a conscious mind. I mentioned that the symptoms typically associated with conversion disorders are simply not possible from a physiological perspective. Having your hand paralyzed, for example, just your hand, we sometimes call that glove paralysis because it's what a glove would cover. It can't happen because the nerves that stimulate these fingers also stimulate this part of the arm. And so if there was paralysis in this part, there would be paralysis in the arm. If your whole hand was paralyzed, virtually your whole arm would be paralyzed. That's just the way the nerves run. So when you show a pattern of symptoms that cannot happen from physiological problems, you know that it has to be something else. Now, what do we know about these disorders so far? Freud recognized, and that's been verified by a lot of research since, that trauma seems to be a triggering mechanism for most, if not all, of these disorders. Freud also speculated that repression was important. There's a lot more debate about that. In fact, there's debate about the reality of repression in general. So his idea was that it was a converting of a psychological trauma into physical symptoms. Behavioral perspectives, which are dramatically different than a Freudian psychodynamic perspective, also recognizes the existence of trauma and that its temporal arrangement suggests that it's part of the causal chain. Somehow the trauma triggers these symptoms. But it also recognizes that it doesn't trigger the symptoms in everybody. It tends to trigger it in individuals who, for whatever reason, find it more acceptable to be physically ill than to have some sort of psychological problem. People who have looked across cultures have noticed that within our own culture, we rarely see these symptoms except in individuals who come from lower social classes and individuals who have very little understanding of physical disorders. Individuals better trained in physical disorders rarely show the symptoms. And that's true across cultures as well. Cultures that have less understanding of physical disorders are more likely to show these kinds of conversion symptoms. Also, it tends to run in families. So if you have one person with these kinds of symptoms, it's very common to have other people. Now, you may remember, we don't know when it runs in families whether it's genes or the environment or some combination. Our best guess here, based on limited data, is it's probably both. For both somatic symptom and conversion disorders, we tend to use essentially the same treatments. Cognitive behavioral therapy is usually the primary treatment that we use, although there's some variations. First of all, individuals with both of these symptoms tend to have very little social support because they've not established the kind of social relationships that provide that kind of support, symbiotic relationships. So in cognitive behavioral therapy, you start with a lot of initial reassurance because the person desperately needs that. And you also focus on stress reduction because stress is usually the trauma that triggers the symptoms. So if you can manage that stress better, you'll have fewer symptoms. You also try to reduce the natural help-seeking behavior, which is usually to either talk with doctors or to talk with your friends and your coworkers over and over and over again until they don't want to hear it anymore. That tends to be counterproductive because it isolates the person from getting social support that they need. And by the way, we all need. Since these individuals often will seek the doctor so often that they can all but bankrupt an insurance system that is relying on pooling money from a large number of people to pay for the expenses of a relatively small group within there. We typically use gatekeeper physicians whose job it is to look at the symptoms and decide realistically, is it worth this expensive test or this expensive procedure given the evidence that we have? Another disorder is called illness anxiety disorder. That term's actually been around for a while, but you know it by another name, hypochondriasis. These are the people you would call a hypochondriac. They're constantly worried that they have some terrible illness. But unlike somatization disorder, where the individual is presenting a whole series of unrelated symptoms, in illness anxiety disorder, symptoms or physical sensations make the person believe that they have some horrible, deadly disease. And so their focus isn't so much on the symptoms, except that those indicate that they need to be tested for cancer or heart disease or some other serious disease. In general, those tests will not reduce their anxiety. They continue to be concerned about it. And again, we often need gatekeeper physicians to control the amount of testing that is done for people with hypochondriasis. Now, what contributes to illness anxiety disorder? In most cases, what people are experiencing is real. I mean, we have aches and pains all the time. We are constantly stressing our body. Every time you do a little extra work using muscles you haven't used, the next day or two you are very uncomfortable. Sometimes you're going to be short of breath. Those are real things that are just normal reactions. They're not the sign of some horrible underlying condition. Oh, it's possible that those symptoms may be, but there should be other patterns of symptoms if there is some horrible condition. But what's happening is the person is catastrophizing normal feelings. The way they think about it, their cognitions are turning normal feelings into signs of something that's just not there. But like everything else, stress makes it worse. Remember, that's the theme for this course. Stress makes everything worse. Social support makes everything better. Now, stress doesn't cause stuff, but it can trigger it. So being able to manage your stress, getting social support to help you get through stress. Family history is very much a part of what's going on. This tends to run in families. Again, we don't know if that's genes or environment. And sometimes there's some clear secondary gain. If you present physical symptoms, I can't do that because my back hurts too much, and I'm pretty much going to be confined to bed for the next couple of days. It's a pretty good excuse, and a more acceptable excuse for many people for things they really don't want to do anyway. SSRIs, or selective serotonin reuptake inhibitors, seem to be the medication of choice, although their effects are moderate and don't always work with all of the individuals who have illness, anxiety disorder. Cognitive behavioral therapy tends to be more effective. What you do is you identify or help them to identify the symptoms and get them to challenge them. Get them to realize that what they're experiencing is in fact normal so that they don't catastrophize it. Psychodynamic perspective focuses on uncovering these unconscious processes that are going on, but as near as we can tell, it doesn't work very well, and it's certainly not the treatment of choice. In mild cases, education and social support are often enough to overcome, at least until a serious stressor comes along, the symptoms. But in more severe cases, education and support does almost nothing. The last disorder that we will be covering is called psychological factors affecting other medical conditions. Let me start with the bottom line. Psychological factors affect all medical conditions. All medical conditions. Stress makes everything worse, including physical disorders. But there are some disorders that are physical. They're real, but they're very sensitive to psychological phenomena such as stress and social support. They include things like asthma and diabetes and pain disorders. You all know that if you have a bad headache, for example, and you focus your attention on it, the headache gets worse. And if you get distracted, the pain often eases from the distraction. Behavioral and psychological factors have an enormous impact on a variety of disorders. I mean, we sometimes think of psychology and physiology as being completely separate, but we only have one body, and it all works together. We're going to see some examples of that are pretty dramatic in this course as we're going through, and we've already seen some examples of how psychological factors affect physical conditions.